president of the Fondazione Michelangelo in Milan. He's going to discuss pathologic complete response to neoadjuvant treatment with or without atezolizumab in triple-negative early high-risk locally advanced breast cancer. NeoTRIPaPDL1, must be Italian, Michelangelo randomized trial.
Thank you very much, Ken. Yes, it is my pleasure today. I will present the first and initial report on pathological complete response of this trial. And just as a way of introduction, we know, and already Dr. Schmidt has summarized some of the concept that triple-negative breast cancer have a very poor prognosis, usually rapidly progress to distant metastasis and rapidly develop resistance to chemotherapy. It has also been known for the past few years that immune infiltration of triple-negative breast cancer is linked to prognosis and probability of better response to chemotherapy. And we have been known for quite a few years that block of PD-L1 and PD-1 may favor durable responses of triple-negative breast cancer by immune mechanisms themselves, as well as in combination with classical chemotherapy. Lastly, the last year, Dr. Schmidt has published a pivotal trial in which there was a clear and significant progression-free and overall survival benefit upon addition of atezolizumab, the drug that we are using and testing here, to nab-paclitaxel in PD-L1 positive metastatic triple-negative breast cancer. The NeoTRIP trial was open to women with HER2-negative, estrogen receptor and progesterone receptor negative, early high risk or locally advanced unilateral breast cancer. And women did receive either carboplatin plus nab-paclitaxel given weekly for 2 consecutive weeks every 3, or the same chemotherapy with the addition of atezolizumab on day 1 every 3 weeks for 8 cycles, and then they underwent surgery and continued with adjuvant and anthracycline-containing regimen before follow-up. Estrogen receptor, progesterone receptor 2, and PD-L1 were centrally assessed before randomization. We took plenty of tumor and blood that are banked and ready for correlative studies. But today I will present the preliminary report on the neoadjuvant part of the trial. Please note that the primary aim of the study is not pCR in this trial, but event-free survival at 5 years after randomization of the last patient. The main characteristics of the patients that were enrolled into the trial are illustrated here. I would call your attention to the fact that we have 49% of the women with locally advanced tumors, and 56% of the tumors had positive PD-L1 immunohistochemistry with an assay that is different from the assay that is used from pembrolizumab. And the nodal status, only 13% of the women had axillary nodes absent on clinical grounds, although if they had that condition, they needed to also have very large tumors to be enrolled. So in the intent to treat analysis, the rate of pathological complete response was 43.5% with atezolizumab and 40.8% without atezolizumab, for a net difference of 2.63%, and odds ratio 1.1, not statistically significant. In a multivariate analysis, taking into account treatment with atezo or no atezo, PD-L1 expression, positive versus negative, and disease stage, early high risk versus locally advanced, the only variable that was associated with the rate of pathological complete response was a finding of PD-L1 positive immunohistochemistry that was similar in women with tumors that were who received atezolizumab and those who did not receive atezolizumab. The same trend towards a numerically higher rate of clinical overall response with atezolizumab was observed on clinical grounds, but again, 76.1% versus 68.3%, not statistically significant. Treatment-related adverse events for those effects that had an incidence larger than 15% are summarized in this busy slide. On the left of the zero axis, you have the columns related to the atezolizumab group, and on the right of the zero axis, you have the columns for no atezolizumab group. And they show that basically the tolerability was similar in both groups, and the only difference was for abnormal liver transaminases that tended to be significantly more frequent with the atezolizumab administration, although the toxicity was very short-lived and didn't limit the possibility of administering the drug. The immune-related adverse events and diffusion reactions clustered around the atezolizumab arm as expected, and mostly consisted of infusion reaction and hypothyroidism, while all other toxicities were either mild or very rare. So in conclusions, the addition of atezolizumab to MAP, paclitaxel, and carboplatin did not significantly increase the rate of pCR in women with triple-negative breast cancer in the NeoTRIP trial. In multivariate analysis, the presence of PD-L1 expression was the most significant factor influencing the rate of PCR with and without atezolizumab. Treatment-related adverse events were similar with either regimen, except for a significantly higher overall incidence of serious adverse events and liver function test abnormalities with atezolizumab. We have been continuing follow-up for the primary endpoint of event-free survival, and other efficacy endpoints and molecular studies are underway, and I would like to acknowledge all the patients participating in the study and the teams of the participating sites of the NeoTRIP trial. Thank you for your attention.
Questions? Luca, an obvious question is, what's the difference between the prior study, keynote study, and this study? Obviously, the drugs are different. Obviously, the chemotherapy regimen is different. Obviously, the chemotherapy duration of treatment is different. What do you think the difference is? Can you tell us first a little bit about the difference between the drugs?
Well, the drugs are different because pembrolizumab is directly against the PD-1, while atezolizumab hits the PD-L1. At the end of the day, they both interfere with the axis in between PD-1 and PD-L1, and it is largely assumed that mechanistically they will have the same effect at the end of the day, although there are subtle differences that may be not so subtle at the end of the day. The other point is that this trial was designed around event-free survival, not by chance. When we designed the trial, we know that PCR is an extremely powerful predictor of long-term outcome, but this is true for drugs such as chemotherapy. If you move to endocrine therapy, no relationship at all, in spite of the fact that endocrine drugs have saved scores of lives in the past 30 years. When we designed the trial, we had very little knowledge of the subtle mechanism of immune modulation by these drugs. And so we didn't know whether we would have an increase in pathological complete response or an increase in the long-term benefits associated with the administration of the drug.
There's a question, I think, on the webcam.
Yes, thank you. This first question is from Sally Church with Biotech Strategy. Which assay was used for PD-L1 assessment, and was this centrally reviewed?
It was centrally reviewed before randomization. Patient had to have the characterization before being randomized, and it was the Ventana SP142 immunohistochemistry assay that was used throughout, and which is very different from the type of assay that is used for pembrolizumab in the trial that was presented by Professor Schmidt.
Okay, and the second question from Sally Church was there any evaluation of TILs at baseline, and were the groups balanced for this factor?
That is a very, very important question. Infiltrating lymphocytes obviously are a key element in the interpretation of the results, we are rushing in to make all the analysis of the tumor-infiltrating lymphocytes, not only at diagnosis, but also at the several times when we collected them after the first cycle and at surgery, as well as a full assessment of the PDL1 expression at different time points. And we plan to publish and present this data very soon.
There's another question from the webcam.
Not at this time.
The chemotherapy was slightly different, wasn't it, Luca? Both groups had a platinum-based regimen, but the other trial had additional chemotherapy, which probably explains the higher pCR rate, maybe, overall.
It could be. The anthracyclines have a dual potential impact. On the one side, there are outstanding drugs as a cytotoxic chemotherapy. On the other side, they have an effect on IDO, which is a regulator of immune modulation. So there may be a boost of the activity of PDL1 inhibitors by using of anthracyclines. The point is that when we designed the trial, we had no information whatsoever on the possibility of combining atezolizumab with anthracyclines, and we couldn't provide this type of option to women who are potentially cured of their disease.
Any other questions?